Thank you so much for attending today's session. Really excited about this monthly webinar, and at the end I'll also share the upcoming webinars for March. So today's topic is understanding funding options to meet elder care choices. And I think that it is such an important topic because one of the biggest misconceptions outside of not necessarily understanding all the options in healthcare is how to pay for these services. And so we're going to really, hopefully by the end of today's session, you're going to have a broader understanding of what is available and hopefully be able to understand a little bit more about what you may be able to do to access some of those resources. I like this quote. I think it really fits for today's session. It's not the money that matters, it's how you use it that determines its true value. And I think when we're talking about caregiving options, which is always unfortunately having to be tied to finances in many situations, we really have to think about value in several ways. We have to think about value from a personal kind of emotional perception, but also the value that we're receiving for the amount that we're paying. As anything that when we're talking about finances, there's always going to be a disclaimer, and this one is here as well. So this webinar is not meant for financial or legal planning purposes and is educational in nature. Before making any financial decision, it is recommended that you work with your own financial and legal advisors to determine what is the best fit for you. As we go through the slides, you'll see that there are a lot of variations based on different situations, based on state location. So it is impossible to talk about all of the funding options and ensure that everybody's particular situation would be taken under advisement with that. So who needs long-term care? We're going to initially start a little bit about just kind of understanding what long-term care is, what services are covered under that when we talk about long-term care. But over 63% of those 65 and older are in need of long-term care. 37% of those using long-term care are under the age of 65. And the lifetime probability of becoming disabled in at least 2 activities of daily living, which includes things like bathing and dressing and grooming and transferring from your chair to standing position, eating, or of being cognitively impaired is 68% for people age 65 and older. And what we're seeing is an increase in chronic illnesses that are lasting a much longer time because we have the medical interventions to be able to treat some of those, but it does require the assistance in several categories for day-to-day activities. And 33% of Americans do not believe that they will be financially prepared to live to 85. As we plan for the future, most of us plan for our children's college fund, a wedding, or even a vacation. But very few of us actually are planning for the day that we need more help than we can provide ourselves or a loved one. And there's probably several reasons for this. For any of you that were on the session last month, we talked a lot about societal views on aging. And as far as we have come in terms of thinking about how we view aging, we still have an inner voice that often doesn't allow us to really want to think about the aging process. One, because we're concerned about disease that we may have, we're concerned about cognitive changes, we're concerned about a loss of independence, and for many we're also concerned about the end of our lives and how that gets closer, certainly as we get older. oftentimes we're not wanting to think about this plan because we're really overwhelmed by the options. We may not understand all of them, and we may really be thinking about our finances and have always had concerns about our finances, and so this is really just aggravating and enhancing those concerns. And for many of us, we really have misinformation about Medicare, misinformation about how long-term care services are funded. And so again, instead of trying to explore those or learn more about them, we tend to not want to consider them and believe that we'll be okay. We won't need services that would lead us to a place where we'd have to even think about using our finances for something such as long-term care services. There's a lot of infographics out there. AARP has some wonderful ones that really just highlight some of the issues surrounding long-term care and the financial costs. And this one was really focused on looking at the costs not to that individual who is requiring the care, but really the cost for those who are family caregivers and what that does to their own income. So as you think about this issue with your family, as you start planning, it's not just about planning for our seniors' financial needs, but it's also planning for those generations that are going to be providing that care and maybe providing from a personal caregiving level what that would mean. For some, it simply is a matter of not providing the direct care, but having to fly out more regularly, maybe having to make more trips to grandma's house, which is a cost in terms of gas and wear and tear in one's car. So a lot of different costs, and more than 3 out of 4 family caregivers are incurring out-of-pocket costs as a result of caregiving. Again, some of that is because they are taking time out of their work and not getting paid for it. But for many, it's also the long-distance caregiving added out-of-pocket expenses that may be resulting. The other piece, before we begin to explore the actual financial options that are available, as you're thinking about these slides, as you're thinking about how you may talk to family members about this topic, it's often first really important for you to consider what your own family history is around money discussions. For some families, they absolutely do not discuss money. They don't know what their parents made when they were actively working. They may not know what their parents have in terms of Social Security. They may never have shared their own wages after college. No one may know what debts have been incurred and what is still owing. So when you think about your family's dynamic around money, you have to have a realistic view that you're not going to be able to all of a sudden open this discussion wide if it has always been a closed topic. The other piece is that we really need to be conversing versus criticizing. When you do begin to better understand your family member's financial picture, and if it does look initially fairly bleak, if there are more debts than one believed, if there is less savings than one thought, it's really important to kind of be there with them, explore that, make sure that everybody has all the information, make sure that there are financial experts that can be brought in, but don't criticize because it, one, does nothing to change the situation, and 2, will close out the conversation. The other piece is we often find as our parents are aging, as our loved ones are aging, that we want them to make changes. We want them to begin to document wishes, to begin to document their legal decisions around their estate and what's going to happen when they pass away to their estate and who are the heirs. But we have to think about the idea of people in glass houses. I'm a big believer that if we have an expectation for anybody else in our lives to be completing those kind of documents, to be completing financial and legal documents, we ourselves need to be doing that as well. There is very few documents that we would be asking our parents or our aging family members to complete that would not benefit us and anybody over the age of 18. So really think about making sure that you are part of those meetings and that you are actively engaged in doing this paperwork yourself. It's also a great way to bring in that family member, to bring in your aging parents, to say, this is not just something I think you need to do, but this is something that's important for all of our family members, and we recognize how important it is, and we too are going to participate in it. And lastly, around this is really thinking about organizing, making sure that you've asked the questions, that people know where documents are, that they're available and easily accessible. There are also non-financial costs to care options. And when we think about whether we can provide the care ourselves or whether we're going to bring in professional care options, think about the cost, not financial, but emotional, and to our own health if we try to do this all on our own. There's a lot of burnout associated with caregiving. For family members. There's a lot of stress in families where one part of the family may not feel that their siblings are doing as much as they are, and it begins to break down those relationships. There are increased risks to one's health and safety. We begin to take risks on our own health. We start lifting and doing things in terms of body movements that aren't good for our own backs. We begin to reduce our own focus on our own nutrition and our own sleep patterns. And again, that leads to our own disease, our own ill health. We have to think about the legacy that is left behind, both in terms of relationships and then what is happening to the finances for one's estate. Which is truly, it is not necessarily a negative to have to think about that, but particularly when there are a well spouse or well partner that is themselves going to need services down the line, what's left for them when you're starting to make decisions for only one person in the partnership. This slide in longtermcare.gov has some wonderful information. It's one of the resources that I have listed at the end. But there's a variety of options available in the community for care, and each one of them has its own price tag attached. And we're going to talk a little bit as we move forward with each of the funding options, how those funding options may work with any one of these types of services. But right now, when we look at the numbers for the last year, the average per day for a semi-private room in a nursing home is over $205. Now again, this is going to be averages because certain states certainly are higher or lower than these. In a private room, it's going to be over $229. If you're in an assisted care facility, which is going to have a range of service options available in addition to the rent, it's going to be at a base, an average of $3,200. For a home health aide, for a CNA, for a caregiver, the range is going to be between $19 and $21. And adult daycare centers are going to average about $67. Again, different areas of the country are going to have different service rates attached to them and different types of services that may have some other things connected with them, so that we're wanting to make sure we're comparing apples to apples, may also have some different rates. I wanted to briefly talk about some myths and truths of long-term care and funding options. The majority of long-term care is provided in a nursing home. This is one of the biggest myths out there. And I think it's also one of the reasons that seniors often don't want to express that they are having some concerns, that they're having some health issues, that they feel that they need some assistance, because their fear is that they would end up and their only option is going to be to go into a nursing home. When in fact, approximately 80% of individuals who need long-term care receive the care in their own home, provided by both paid and family caregivers as well as professional family caregivers. The need for long-term care is greater than other life trials. This is true. In fact, about 70% of people over the age of 65 will require some type of long-term care services during their lifetime. In comparison, if we think about insurance professionals that cite the probability of losing one's home to a fire is 1 in 1,200, and the chance of having a car accident is 1 in 240. Although most people have car insurance, homeowners insurance, and health insurance, but few have planned to protect themselves against those risks of long-term care. And finally, most people are covered by health insurance policies for long-term care. And that is also a myth. Studies suggest that almost 1/3 of consumers think they are covered by an existing insurance of some type, but they are not. It's a myth that health insurance policies will cover long-term care. Even Medicare supplement policies are not designed to do this. And disability insurance typically protects us against the loss of income due to a disability, but not the service provision of care that's required. So after some of those myths and truths, let's talk about Medicare. Federally funded health insurance program is what Medicare truly is. There are actually 4 parts to Medicare programs. Part A and B is referred to as Original Medicare. Part C is referred to as Medicare Advantage, and Part D is prescription coverage. We're going to talk about each one of those. Medicare Part A is referred to as hospital insurance. This coverage includes coverage for inpatient hospital care, limited time in a nursing care facility, which we're going to talk about in a few minutes, limited home health services, which we're also going to discuss, and hospice services. Most individuals do not pay for Part A, as it's paid through Medicare taxes that were collected while you have worked. It is not anticipated that you're going to be able to remember all of these details. Again, these webinars are always recorded and available on our YouTube channel. But in addition, Medicare.gov, which I talk about at the end, is a wonderful resource, and they have a great book called Medicare and You that is a free PDF that you can download and print, or you can ask them to send you a copy. In fact, everybody who receives Medicare for the first time will actually receive the latest copy of that. Medicare Part A, the benefits, the deductibles, the co-pays, those change every year based on some of the different kind of economics that are going on during that year, that previous year. And for Medicare Part A, right now, per benefit period, the deductible is $1,300, which means that if you do go into a hospital, you're going to be paying the first $1,300 of that hospital stay or that nursing home stay if you're going into the nursing home. The hospital, for the first 1 to 60 days, there is no payment from you. For days 61 through 90, it's $329 a day in the hospital, and days 91 and beyond, it is over $600 a day. But as we typically know, hospital stays are rarely even needing the 1 to 60 days. You know, it's hard to even be able to be in a hospital for 3 days, let alone thinking about these others. So, but it is important to understand the deductible aspects and to understand that there are different benefit periods. Medicare Part B is referred to as medical insurance. This is what is going to cover your non-hospital medical expenses, your doctor's office, hospital visits, blood tests that are prescribed, x-rays, diabetic screenings and supplies, and outpatient hospital care. Again, it's always important to check to make sure that the tests that are being asked to be performed have met the guidelines that Medicare has set in terms of how many you can do at any period of time to ensure that they are going to be covered. You will pay a monthly premium for this part of Medicare, and this fee does increase with income after a certain level. And the fee is deducted from your Social Security one receives, or it's sent to Medicare monthly if you are not receiving Social Security. Medicare Part B also has premiums, deductibles, and coinsurance. Medicare Part C is referred to as Medicare Advantage plans. So many people are enrolled in a Medicare Advantage plan, often referred to as a Medicare Supplement plan. And to do so, you need to be enrolled first in both Part A and Part B, and you are paying for Part B. You're still in the Medicare program, but you are receiving your benefits through the plan instead of through original Medicare. So companies such as Humana, United, Aetna, all have different Medicare Advantage plans, and plans are different within every state. And within each of the insurance companies, there's typically several different plans with a variety of premium costs based on what additional services and benefits you will receive. They often will have a higher premium cost, which would be in addition to what you are already paying for Part B. Again, Medicare Part C is voluntary. You do not have to join a Medicare Part C program, but we'll talk about what some of the benefits are. One of the benefits is that you don't have there is an out-of-pocket maximum with Medicare Advantage plans, unlike original Medicare, where there is no maximum for how much you could be covered out of pocket. Medicare Part C plans help cover certain deductibles, coinsurance, and out-of-pocket costs. For example, when we're talking about a nursing home stay, when there is a deductible, they will cover it as long as Medicare has already certified that it is a necessary program. They may offer higher or lower than the typical 20% coinsurance charged by original Medicare. Many Medicare Advantage programs cover vision, dental, and nursing home care. And you must enroll during open enrollment periods, and most state, area, agency on aging programs will help to sort out options available in your state. And many have computer programs which really allow you to kind of enter the type of services you're looking for, what you have, if you have any pre-existing conditions, and it will give you a list of those programs that may best match your need. Medicare Part D is often referred to as the prescription drug coverage plan. Original Medicare does not cover prescription drugs that are outpatient and are not being done in the doctor's office. Many add a prescription drug plan, Part D, or choose a Medicare Advantage plan that includes Part D coverage. Part D plans are required to cover certain types of drugs, but each plan may choose specific drugs it covers, and it's really important to review each plan's drug list to see if your drugs are covered and at what level. This is also where it's really important to work with somebody who can enter your present prescriptions into a computer and identify which plan would fit best for you. Some large pharmacies will assist you with this during that open enrollment time, because again, for instance, if you are someone who's diabetic and uses medicine for your diabetes, there are going to be some plans that are going to cover that better than others. And the premiums and deductibles will all be varied depending on the Part D plan that you choose. So how does Medicare work with some of the long-term care services that we are needing? So Medicare will help pay for a short stay in a skilled nursing facility if you meet the following conditions. First, you've had a recent prior hospital inpatient stay of at least 3 days. Second, that you were admitted to a Medicare certified nursing facility within 30 days of that prior eligible hospital stay. And you need skilled care, such as skilled nursing services, physical therapy, occupational therapy, or speech therapy. And when we're talking about skilled nursing services, we're talking about services that are being provided by an RN who is needing to assess, observe, and make adjustments. Often this could be for someone who has a newly diagnosed diagnosis or is now using insulin for the first time or oxygen for the first time, and may need some training and some monitoring for how those medications are working and be able to report that. Or it could be that you're going into the nursing facility after a hip fracture for physical therapy or after a stroke. If you meet all these conditions, Medicare will pay for some of your costs for up to 100 days. For the first 20 days of eligibility, Medicare pays up to 100% of your costs, and for days 21 through 100, as of 2017, you would pay a copay of $165 a day, and Medicare would pay the balance. The copay may be covered under a Medicare Advantage plan. As we discussed earlier, that's the Medicare Plan Base C. So how does Medicare cover some other services such as home health care? So Medicare will pay for home health care if you meet several conditions. It needs to be physician ordered. It needs to be part-time or intermittent skilled nursing care, physical therapy, occupational therapy, speech therapy from a Medicare certified home health agency. And occupational therapy alone would not qualify someone to receive that. But typically, occupational therapy is going to be in conjunction with a physical therapy program. So this is in one's own home, or if you're living in an assisted living or an independent living senior complex. Medical social services are also included to help cope with social, psychological, cultural, and medical issues from an illness. Medical supplies and durable medical equipment with a 20% copay will be covered with physician orders and under specific guidelines. And one of the key factors of getting home health services is that you are homebound, which means that it is difficult for you to get out into the community to get your care, for instance, through a physical therapy treatment center. It doesn't mean that you just can't drive, but that even getting into a cab or getting into the car of a friend or family member would be really taxing, and that by the time you got to the clinic, it would be very difficult for you to be able to do anything else. Home health aid services are only covered while Medicare is covering skilled services through a Medicare certified home health agency. Hospice. Hospice is a program for those who have advanced illnesses and have either chosen not to continue treatment or treatment is no longer an option for them. It is physician ordered. One is not expected to live for more than 6 months from the start of hospice services. One has accepted the hospice philosophy of care. Medicare will cover your medications that control the symptoms of the illness that has gotten you into the hospice program. Care can be provided in any home setting as long as that setting is not receiving other Medicare payments for your stay. And unlike home health services, when you receive hospice, you do not need to be homebound. In fact, your hospice team will try to enhance your symptom management so that you are able to get out into the community. Services are broad and include intermittent, which means that they are not coming every day and they're not scheduled, but registered nurses, social workers, chaplain, volunteer are coming throughout the week to provide assessment and assistance. There's a home health aide that you can use for bathing, and again, that's going to be intermittent, not daily, and not long hours of care. It would be for the bath visit only. They also include grief counseling. Many hospice programs include music therapy and/or massage therapy, but those are not covered directly under Medicare. Those are typically covered under charity funds and foundation and donated monies. There is limited continuous care services for pain or other symptoms for typically up to 72 hours in hopes that someone could avoid hospitalization. And those are typically rare because the hospice team, with collaboration with your physician and pharmacists, are really good ensuring that people's symptoms are well maintained despite the advancing illness. So it's always good to know what something covers, but it's also important to know what something doesn't cover. And in this case, Medicare does not cover, in all cases, Medicare does not cover what's considered custodial care, which is non-medical, meaning that it is not being provided by a registered nurse or a licensed physical therapist, and it is provided either at home, in a nursing or assisted living facility that includes the activities of daily living, things like bathing and eating and dressing and using the toilet, and it's for someone who's unable to fully perform those activities without help. So Medicare does not cover those type of services. And for most people, those are the very services that we need as we're aging. We need, as the percentage of individuals who are having trouble with more than two of these, those are the type of things that we need much more regularly than a nurse to be providing wound care or physical therapist to be providing intensive therapy services. Medicare does not cover meals delivered to your home. And Medicare will not cover certain durable medical equipment unless it's part of hospice, such as a bath chair, a commode, which helps, goes over the toilet, raises that toilet up, grab bars, and certain walkers. And these, though, are very important to maintaining one's independence, safety, and minimizing risk in your home. However, Medicare does not cover those. So let's switch to something that is often confused with Medicare, and that's Medicaid. And if you think about the care and the aid, and Medicaid is a federally funded program that's administered by the states, which is why there are different names in different states for this program, which leads to some of the confusion. And there's often different eligibility and some guidelines in different states, which also can lead to some confusion, particularly when families are living in different states and may be needing programs that are similar, called different things, and eligibility is different. Available to certain low-income individuals and families based on eligibility criteria recognized by federal and state law. And we're really focusing on the Medicaid that is specific to the senior population. To be eligible, one must have limited income and assets. There is a 5-year look-back period. This changed several years ago. Every state used to have a different look-back period. And basically what a look-back period is that they are going to look to see what has happened to your assets over that 5-year period, so that you are not transitioning those or giving those to family or friends over a certain number of dollar amount each month, in some hope of one being able to be eligible for Medicaid, or just because you're being really generous and wanting to provide for maybe the college education of a grandchild, but now leaving that person in a position where they can't fund their own care and needing to turn to the state and federal government. The amount of income you have varies by state. Income will include that they're going to look at regular benefit payments such as Social Security, retirement, disability payments, veteran benefits, pensions, salaries, wages, interest from bank accounts and CDs, dividends, and even payments to which you're entitled even if you haven't received all of the payment. Rental income, things like that. And even if it's a joint payment, the state will allocate half to you and half to a spouse. You can see so that they really are looking at a lot of different varied incomes, sources that you have. Amount of assets you can have will vary by the state, but in several states, an individual can retain $2,000 in assets, and a married couple can retain $3,000 in assets. And again, that's going to vary by states, and some of those numbers are higher in other states. Community spouses may keep additional assets under certain circumstances, and there are formulas to be able to look at that and how to allocate those assets to a community spouse. Assets that are typically counted include checking and savings accounts, stocks and bonds, CDs, real property other than your primary residence, and additional motor vehicles if you have more than one. Assets that aren't counted: primary residence, personal property and household goods, one motor vehicle, life insurance with a face value under $1,500. And if you think about that, many people have life insurance policies with a much greater face value. Up to $1,500 in a burial fund, certain burial arrangements such as a pre-need burial agreement, so that that money is already allocated for some of those burial programs, and assets held in specific kinds of trusts, and that varies by state. So again, really important to be getting guidance by a state-specific specialist. After one's eligibility requirements are met and you have needs assessed by a county case manager for long-term care services, you may be eligible for community-based care such as home care. And if your needs exceed a dollar amount allowed by Medicaid, you may need to receive that care in a nursing home if you can't be at home without that level of care. But typically, states will have someone move into a nursing home if the care in the home exceeds what the average state nursing home fee is. Community services are sometimes funded through waivers or community-based state programs. So when you're getting those community dollars paying for your service, it may not be called Medicaid. It may be called, for instance, in Arizona, it's called Access. So again, some of the language is different depending on the state and depending on the program itself. Assisted living facilities may be eligible, but not all facilities will accept this type of payment, and many have long waiting periods. And often residents using this funding for payment may be required to share an apartment suite. So again, while Medicaid is certainly a needed option for many people, it often limits the type of options and choices that people may have in terms of having free choice as to the exact type of care service that they're wanting. Veteran programs. So this is something that a lot of individuals are not accessing, despite the fact that 1 in 3 seniors in this country is a veteran or surviving spouse of a veteran. And Veteran Aid and Attendance is a little-known program that many do not explore because they are not aware of the program itself. As with any of these programs, there are a variety of eligibility requirements, application guidelines. So it's hard to always synthesize these down to a few slides. My hope is, again, that I will kind of share this information of things that you may not be aware of, and then you'll be able to explore on your own with a professional guiding you, with a family member, and find out specifically in your case how this will work. But general eligibility is that it is for veterans or surviving spouse of a veteran who served 90 consecutive days of active duty with at least 1 day during wartime period. And many people don't think about that their own eligibility because they may have served stateside and not in a foreign country during that wartime. However, that is not a necessity and a requirement. It is just that you have served during what the government has deemed that wartime period, which is often a longer period of time than sometimes we think of for the direct conflict that was happening. You must have a non-service related medical condition. So this is not for service related disabilities. And the condition must require assistance with daily activities such as bathing, dressing, eating, medication management, housekeeping, laundry, meal prep. So again, we keep seeing these activities of daily living, sometimes referred to or often referred to from the healthcare professional side as ADLs. But we see these a lot in terms of things that kind of connect us for eligibility. You need to meet asset requirements, but different than, for instance, Medicaid, this will exclude your home and counts in the care that you're receiving. You need to meet medical expense to income ratio, and depending on who and if it is for both the veteran and a spouse, or a spouse alone, or two veterans who are married, the range of monthly benefits can range between $1,300 and $2,700. It's important to note that the VA does not allow anyone to receive payment for assisting with VA paperwork. Oftentimes, attorneys will assist with VA aid and attendance paperwork as part of an estate plan, so that the VA piece of it is just one part of the estate plan, which is where the payment is going to. Family members can assist with filing the application through the va.gov website, and every county has a county veteran service officer that can assist, and oftentimes organizations such as the VFW or American Legion will also have someone there that will assist with this type of paperwork. You want to be aware that there are other entities that will assist with filing applications and getting veterans approved, but they may also be trying to develop a financial plan for remaining assets, including annuities, which may or may not be the right choice for a senior. And it is always prudent to seek a second opinion with a certified financial planner prior. Receiving VA aid and attendance pension may make you ineligible for Medicaid and other income-based programs, as it could be counted towards your monthly income, putting you over guidelines. But many states now do require that all veterans who would be eligible apply for VA aid and attendance at the time they're applying for Medicaid benefits, because of course, again, the state and federal governments are wanting to kind of first get through one level of option before then providing a secondary level. So they often go hand in hand, and you do have to show that you've applied for one, and it may limit some of the income or available resources for the other. VA aid and attendance requirements in terms of assets are much higher, but there isn't a standard number that they put out in terms of what the asset level is. And often it's looking at, based on the assets that one has, is there enough to be able to cover some of the costs, or would it be a burden to that family? So the asset level is higher, then it's certainly higher than it is with Medicaid, but there isn't a set number that they put out for that. I think it's important to kind of think about all options, and many hear about reverse mortgages. And this can be an option for some individuals who want to stay in their home, who have equity in their home, but don't necessarily have a lot of freed cash to be able to provide and get community-based services. It is something to look towards and to explore, But again, it is not something that is a good fit for all seniors. Seniors that are over the age of 62 may consider a reverse mortgage. So there is an age requirement. It is a loan against one's home that you don't pay back for as long as you live in your home. So different than a typical mortgage where you are paying monthly. In this situation, you're not paying monthly, but it's taking each month, it's taking money out of the equity that is there. These funds can be received as a lump sum, a monthly payout, or as a line of credit, and there's a variety of options depending on the reverse mortgage. It's important to meet with a reverse mortgage counselor, separate from the mortgage broker, to sort out the pros and cons. And again, oftentimes the area agency on aging organizations in one state will have reverse mortgage counselors. It does not require monthly mortgage payments, and the loan is repaid after the borrower moves out or dies. Long-term care insurance is another one of the ways that many people, and certainly we're seeing an increase in this because more and more people have purchased these policies, are paying for care. When you're 50-something, it's hard to imagine that one day you'll not be able to take care of all of your personal needs and that others would need to assist you in day-to-day care. However, as I shared earlier, we all buy home insurance, yet the chance of losing a home to a fire is 1 in 1,200. We all have car insurance, but having a car accident, we have a chance of 1 in 240. But 70% of adults will need long-term care during their lifetime. Long-term care insurance is a way that helps to finance long-term care services, and it can be purchased individually, and more, it's a benefit through employers. However, it's important to note that not all employer plans are portable once you leave the employer, or the rate that you were receiving as an employee for that plan is going to be much higher if you're able to convert it to an individual plan. Today, most policies cover a variety of care options, including home care, adult daycare, assisted living, and nursing home care. And long-term care insurance can ensure that you have options when your care needs increase, and that decisions about your care will be made based on need, choice, and goals, and not on conserving assets. There's many different things that go into affecting the cost of what a long-term care insurance policy is going to cost you for a premium, and that's at the initial premium. The first is age at policy issue. The earlier you purchase, the less your policy premium is going to be, monthly or yearly. And it's also important to think about age when you're purchasing this, because if most policies, when you have any kind of pre-existing condition, if it's a condition that could enhance the chances that you're going to need services as you age, then the chance of either acceptance into that long-term care insurance policy is greatly reduced, or the fee and the premium will go up. So really thinking about when you purchase the policy and begin the policy. How the policy is designed, and we're going to talk about what those design factors are. Many policies have different kinds of riders, such as an automatic inflation rider. So every year, the daily benefit of what you're getting in your insurance plan would go up, but to have such a rider is going to cost more money on the premium. Where you're at with your health. Are there pre-existing conditions? Are those pre-existing conditions ones that are going to increase and enhance your chance and need for care? Things even like osteoporosis, bone scan density tests that show the beginning of osteoporosis can increase the policy premium because the insurance company sees that then as a higher risk for needing care and for requiring services down the line. There are a lot of programs where a marital or couple purchasing a plan together will reduce the cost And nowadays there are many different plans that if one's not using their service and they've maybe passed away, then those benefits can be transferred to the other part of the couple. And again, all of those kind of conversions and payout options often are going to add some additional cost to the premium. Is it a group-sponsored plan? Again, group-sponsored plans are often going to be less expensive, but oftentimes, if you need the benefit after you've left, you then have to convert it to an individual plan. The elimination period, and that is how long are you waiting until you're going to be able to receive services. If we think about Medicare, and while the first 20 days may be covered in a nursing home, and then after the 21st day there's a copay, how much of those copays could you pay for before maybe having the assistance of a long-term care insurance policy? How many days of home care services can you pay privately without reducing your assets to such a degree? How many days in an assisted living would you feel comfortable paying out privately? The lower the waiting period before the services kick in, the benefits kick in, the higher your premium. How long do these benefits last? Is there a lifetime benefit, or is it for the 3 years that you have that daily and monthly benefit of that kind of pot of money that you're able to receive? And what is that daily or monthly benefit? Is it that you're getting $30 a day to be able to use towards your care, or do you have a policy that pays you $100, $200, $300 a day? Of course, the more money that you can pull out, the higher the premium. It used to be that when you had this kind of benefit, if you didn't use it and you passed away, the policy just ended and you had paid out those premiums. Now there's a lot of different payout options, many which turn into a life insurance policy or turn into other kinds of kind of financial funding sources. So lots of different ways to look at it, and really my recommendation is to utilize a broker and not an individual insurance person who's only selling one type of policy, because everybody is going to benefit differently depending on the policy itself and which company you're utilizing. Other considerations for long-term care insurance: there can be some tax benefits that you want to talk with your CPA about, dependent on your state, and whether there's any benefit for having a long-term care insurance policy. And many states also have what's called a long-term care partnership insurance policy that works in somewhat of a collaboration with being able to get Medicaid if and when the long-term care insurance benefit runs out, without having to reduce your assets down farther. So definitely things to be thinking about, but every state is going to be different. If the premiums for long-term care insurance would jeopardize your being able to pay for necessary items such as housing, food, medication, or you foresee that your retirement income would not allow you to continue covering your premiums, you really want to carefully weigh if having a long-term care insurance policy is the best for you, as you may qualify very quickly for something like Medicaid because your income and assets are going to be closer to those levels. If you can easily self-fund your long-term care with your own bank accounts without jeopardizing your spouse or partner's ability to self-fund their own long-term care needs, then you also may not need to have something like a long-term care insurance policy. However, I've known several people who could self-fund, but they prefer to have the peace of mind of this backup insurance for care, and that they can leave a larger inheritance to their heirs, and they also feel that their choices for care will not be based on financial decisions, but their own decision of which kind of care they want. And again, consider working with a broker rather than an agent. Planning ahead equals successful aging. So it's really important to think about these type of things prior to needing care. We certainly think about when we look at long-term care insurance that you can't get long-term care insurance at the time that you need the service. And so it's something that you have to plan for, you have to think about. You're going to have to determine what kinds of options you would want earlier on. And oftentimes what I see when I've worked with families is that once they've recognized the needs of their parents or the person they're caring for, and the some of the more limited options based on finances, they themselves have determined to start exploring a long-term care insurance policy for themselves. Again, in that situation, it won't help the family member we're caring for in that moment and making decisions for, but it will help for those who are looking ahead for their own care needs. The other piece is by planning ahead, we can minimize our own risk of injury or illness, which is our first defense against high long-term care costs. Those can include things like having a home safety assessment done. Synergy HomeCare provides complimentary home safety assessments to be able to look at, are there simple home modifications that can be done? Are there ways that we can use durable medical equipment and other types of devices to increase independence and safety? Again, sometimes it is as simple as removing scatter rugs throughout the home to minimize a risk of a fall and a break and something that could lead to a rehab stay and often to a decline in all other aspects of one's health. It's important to think about initiating services before a crisis. It's difficult to begin to think that we can't provide for our own needs. However, having a caregiver, for instance, come into the home one time a week to assist with household tasks that both tax one's energy and increase one's risk of a fall by maybe navigating the stairs to the laundry or reaching for items on a ladder, or the chance of an accident, driving despite reduced vision or response rate, or taking a shower or bath without assistance, will reduce your chances of needing more services that are costly financially, and which also reduce your options to stay in the community home. So when we think about goals, if we think about asking both ourselves, what is our goal for our aging family members? What is our goal for ourselves if we are over the age of 50 or 60 or 70? What are our goals? And what can we do to ensure that we can reach those? The gentleman that I met with once who said that his goal was to stay in his home and care for his wife who had advancing Alzheimer's, and initially rebuked his kids' option of bringing in someone to assist with the yard maintenance, to assist with doing homemaker tasks, to assist with helping his wife take a bath, began to recognize when he himself heard what his goal was, and he realized the risks that he was taking and minimizing his chances of being able to meet those goals, became much more open to having that caregiver come into his home, to having and hiring that lawn service to take care of his lawn and take care of his snow removal in living in Minnesota. It was only when he began to think about how easily the goals that he had set for himself could be jeopardized if he didn't do some of the even simplest and smallest steps towards taking that first step in getting and funding some care needs. There's a lot of legal planning tools that can be done at the same time that we're talking about financials, including considering a financial power of attorney, which would allow somebody else to help make financial decisions if we were not able to for a variety of reasons. Putting together an estate plan or a trust, those are all things that you will want to discuss with an attorney because it is a different situation for everyone, and really wanting to look at all the ramifications of completing any one of those. Healthcare directives is something we're actually going to be talking about next month. And healthcare directives are documents that allow you to make choices about your healthcare decisions and appoint somebody to make and be your voice if you are unable to make those decisions yourself. Many resources went into developing this PowerPoint, including Medicare.gov, longtermcare.gov, va.gov, socialsecurity.gov, and the National Academy of Elder Law Attorneys, as well as a University of Minnesota education program called Financing Long-Term Care. As you can see, the majority of the resources I've used are .gov resources. I like utilizing those because, again, their focus and the reason that they're providing information is simply for providing information and not also trying to maybe have another different program inserted in it, and we can be better assured that everything is up to date and has the newest and latest year's information. The upcoming Synergy webinars, as if you've already been on one of these webinars, you know that we have one of these a month. March is a special month, and we're actually going to have 2 of them. If you like the Synergy Home Care Facebook page, you will be kept current on all the upcoming webinars and articles, in addition to articles about caregiving and seniors. You can also email me at Carla Sutter, CarlaSutter, at synergyhomecare.com to be added to our email newsletter. On March 14th, we're going to be having the next webinar is Advanced Care Planning and Healthcare Directives, Communicating and Documenting Your Wishes. I encourage all of you to attend. This is a document that is beneficial to anyone over the age of 18. We're going to discuss that in advance of April being National Healthcare Decisions Day. And on March 29th, we're going to talk about aging with purpose and planning for a meaningful retirement. March 14th, we're going to be having that session at 3 o'clock Eastern, and March 29th, it's at 2 o'clock Eastern because we've then been changed, the clocks will have changed. As always, if you are somebody that is engaged and interested in helping families and clients, we have caregiver opportunities throughout the country, and if you are wanting a career that really makes a difference, please contact us, and you can go on synergyhomecare.com. We also have many people who, after really learning and understanding the depth of home care options and community resource options, and want to learn more about how they can also be a resource for families and clients, and maybe interested in learning about how to become part of the Synergy Home Care system, you can also contact us at synergyhomecarefranchise.com. I know that there's some individuals who have provided some information about some other community Medicaid programs and pooled trusts. Again, because there's so much different information about all of these programs, it is impossible to try and put every piece into it without trying to confuse the issue. So again, as I've shared throughout, these are programs that you will want to explore on your own state websites. And you can always do that by, for instance, looking up Medicaid and then the state you're in, and go to your state website to learn more, or Medicare.gov, or any of the long-term care insurance program sites that I shared as well. So yes, there are certainly other aspects to many of these programs, and again, just too many to be able to mention in one hour. Please contact and go to the Synergy Home Care YouTube channel if you would like to see this again, or share it with somebody else. And if you are looking for your certificate of attendance, please contact us at Carla Sutter at synergyhomecare.com, and I will send that to you as well. So I really appreciate your attendance, and again, if you do need that certificate of attendance, you can contact us at Carla Sutter at synergyhomecare.com. Thank you again for all of your time, and look forward